Hey, welcome to Osteo Boston. This is Shelley Gladstein. I'm the host tonight, and I just want to say how excited I am to have Dr. Nancy Lane with us. If you're here live and you're a member of Osteo Boston, or if you're on our YouTube audience, I think you're going to really enjoy hearing a lot about um, bone health and this fabulous woman's uh, gains in that area in her research. So anyway, I'm going to go ahead and have Barbara come on, and thank you.
Hello, everyone. Our speaker tonight is Dr. Nancy Lane. She is a distinguished professor of medicine, rheumatology, and aging research at the University of California, Davis School of Medicine, where she has worked for the past 20 years. She is also the director of the K-12 NIH Building Interdisciplinary Research Careers in Women's Health, and she is the principal investigator of the NIH-funded program on sex differences and musculoskeletal diseases across the lifespan. Now, a little bit about her research. She is an internationally recognized scientist in the fields of both osteoporosis and osteoarthritis. Her translational research team has been instrumental in defining the role of glucocorticoids in bone fragility, including their effects on cell stress and vulnerable cell populations, including osteocytes. As a faculty member at the University of California at San Francisco, she pioneered a seminal clinical trial to demonstrate that daily injections of the hormone PTH could reverse glucocorticoid-induced osteoporosis. After transitioning to UC Davis, Dr. Lane developed a novel compound to direct stem cells to the bone to grow new bone and treat osteoporosis. In addition, she has uncovered novel genetic variations that predispose individuals to osteoarthritis. She has also studied novel treatments for osteoarthritis. Dr. Lane organized and currently directs an NIH-funded junior faculty grant writing workshop that has taught over 300 junior faculty in musculoskeletal medicine grant writing skills that has resulted in a 45% success rate in applicants receiving research grants. And this has been from 2006 to the present. Among her many honors and as a member of many boards, Dr. Lane was elected to the Association of American Physicians in 2006. She has been named Best Doctors in America annually since 2004. She continues to have an active rheumatology practice. Let us now welcome Dr. Nancy Lane.
Absolutely. And one last thing I want to share is that she is also one of the very few that has received the Fellow of the National Academy of Inventors in 2022. So we're pretty excited to have Dr. Lane. Welcome, Dr. Lane.
Well, thank you all for that wonderful introduction. I hope you can all hear me. I wasn't, I'm just a normal person that gets up every day and goes to work. And when I heard that Osteo Boston wanted to hear from me, I said that was very nice. Very nice. I don't know everybody's background, and I probably should have researched a little bit, but I'm going to ask you all to put on your Google, what are they called? Like the virtual reality glasses for the next maybe half an hour and 45 minutes, because I'm going to show you some things that I have been a part of for the last 5 years that have taught me more about the skeleton than I have known in my entire career. And I feel pretty good about what I've done in my career. But over the last 5 years, I've worked with some scientists that leave me in the dust with that, I will start a bit and tell you about a couple of new things we've discovered. By the way, I'm going to show you some things that are very technical because I don't have the software on my computer to take all the published figures apart. But don't worry,
That's okay.
don't worry about not getting all the fine details. Number one, I don't fully understand them all, and number two, it won't change your understanding. So with that, let me see if I can get, there we go. Okay. So I'm going to kind of say goodbye to all of you that I can see so I can see my slides. Okay. So this is Osteoboston. So let me tell you my feeling about where we are in the world of osteoporosis. I think we're great at diagnosing and treating it, just outstanding. I think we have very effective therapies for mild, moderate, and severe disease. We're also very lucky that these medications have a pretty good, strong safety record. And over time, we've learned some things about safety that have made us smarter as clinicians in treating our patients. And some of you may know over the last 5 or 6 years have been wonderful new therapies that have become available for individuals that have rare bone diseases like osteogenesis imperfecta and things you maybe never heard of, but X-linked hypophosphatasia. However, there are still some gaps. And one of our gaps is that we really don't have a strong understanding of the cellular activities related to, if you will, regeneration of the skeleton. Or, as you will hear from me ad nauseum tonight, about skeletal stem cells. And where we have gaps, and where I will show you some of the progress, is we really haven't discovered the ways to harness skeletal stem cells to augment peak bone mass. And for those of you, when we talk about stem cells, we talk about cells that self-renew in the bone marrow, that they divide so that they continuously divide or self-renew so that we can continue to have a source of, if you will, precursor cells for these cells become osteoblasts. And some of you have heard about stem cells. There's 2 types of stem cells we talk about. We talk about hematopoietic stem cells, which give us the blood cells, and you called Osteoboston, and Boston is a wonderful area for the understanding hematopoietic stem cells, and they are used to transplant for patients that have malignancies. Skeletal stem cells or mesenchymal stem cells are the other kind of stem cells that become self-renew and become the connective tissues in the bone in the body. And those are the cells that we're going to be talking about tonight. See if I can figure out how to make not sure why I'm not, there we go. Okay. Now, some of you may have seen this many times, is how we talk about bone mass over the age in years. And all of us are gaining bone up until about the age of 25. And men get a higher peak bone mass than women, and they hang on to it longer till they're about 70, 75. And then they start having a decrease in bone mass, and this is where we start to see men fracturing. Women, we have peak bone mass about the same as men, about the age of 25. And we hang on to it for a while. We say our bone remodeling is coupled. But then with menopause, unless we get treatment, we lose some of our bone. And then that goes away. That fast loss goes away. And then like men, about the age of 65 or so, we have a slow bone loss that's probably related to age. But remember, women don't get as much, and we have that time that we lose it through menopause, and that's different than men. Okay. Now, I'm going into the science, but don't panic. All right. There was a woman at UCSF, Candace Hubert, and her group, she was working with Holly Ingram at UCSF. They study this part of the hypothalamus called the arcuate nucleus. And they study the KISS neurons, which are part of the arcuate nucleus. And don't worry about the technical pieces here. I'm we're going high level here. And these KISS neurons that are in the arcuate nucleus have an estrogen receptor. And Candace was interested to actually what would happen to mice, female mice, if she removed the estrogen receptor out of the arcuate nucleus of the hypothalamus. And this area of the hypothalamus is involved with energy and also other things. So she took out the estrogen receptor in these KISS neurons, and she didn't see any difference in weight. She didn't see any difference in much of anything. They ate the same, their lean mass was the same. But then she said, well, the estrogen receptor might have something to do with bone mass. And what she found was in these mice, these female mice, that she took the estrogen receptor off the KISS neurons, they had higher bone mass, but the males did not. Well, Candace thought that was kind of interesting. So she told her laboratory supervisor about it. She said, look, I've taken the estrogen receptor out of these cells in the arcuate nucleus. And they did it with very sophisticated molecular biology with these Krelocks, but don't worry about that. And lo and behold, these mice had more bone mass, as I'm showing you here, micro CTs. And so, and they looked at the spine, and they looked at the femur, and they said, boy, there's a lot more bone mass here. So they said, well, if you have something you changed in the brain that then works on the skeleton, maybe there's something circulating that changed in the hypothalamus and got down to the skeleton. So they did something that we do in the laboratory. They sewed two mice together, okay? They put a wild type, and then they sewed a wild type and a mutant together. Because if the mutant had something circulating that would increase bone mass, then you would see the bone mass in this wild type go up. But if you put two mice together that were wild type, you wouldn't see much of anything except maybe a little bit of increased bone mass because they gain bone when they get older. So what did they find? Well, look, when you saw the wild type, sewed to the wild type, no biggie. But when you put the wild type and you sewed it to the mutant without the estrogen receptor, look, the bone mass went up. Bingo, there's something here that is circulating when you change that estrogen receptor in the KISS neurons of the arc that got to the bone cells and said, make bone, and the femurs also. So that got everybody pretty excited. Now, I don't want you to spend too much time on this, except look over here where my pointer is, and you can see that the distance between these markers is how we measure bone formation. And in the animals that had the estrogen receptor removed, they were making more bone. And when you looked at the actual bone tissue, I showed you before a measure of the amount of mineral, which is just like all of us getting a bone mineral density. We do it for mice, but when you look at the tissue with and you look at the actual bone tissue, you can see that bone formation rate was up and mineralizing surface and all the things to suggest that there was new bone being made. So, and this is actually genes that are being expressed. And I don't want you to get too excited by this, but when you have orange, they're upregulated, and when they're dark, they're downregulated. And there were some changes there, but I don't want you to spend too much time on that. Okay, so then they did something that I truly thought was rather, as I would say, off the bell-shaped curve. I'm an older person. I'm fairly traditional. The new generation of scientists in the lab are much more, they're brave, and they do things that I would never have done. But what they did was they said, okay, they took this estrogen receptor off these cells, and then somehow they changed that cell so that it made some factor that went down to the bone and said, make bone. So they said that factor must be in the brain. So what they did was they actually put some skeletal stem cells into the brain of the mice. Okay, right into the brain, they put skeletal stem cells. And what they actually found was they grew bone in the brain of these mice, suggesting that whatever was happening, it was coming from the bone. And then they looked at some other stuff, which I don't want you to get too involved with. So the next question that became important, oh, and this is the picture here up top. I don't know if you, oh, I have to go back, hang on. I hope you can all see it. This is putting the bone cells into the brain, and then this is imaging the brain of these mice, and you can see that there's more bone, there's mineral, which shouldn't have mineral in the brain, right? Which is showing us that that factor's coming from there. Okay. And then the next thing we did, which was the new piece for me, was we started looking very carefully at the cells in the bone marrow to see what cells were actually affected. And that's when, for me, I became acquainted with the skeletal stem cell. As I mentioned to you all, there's two major types of stem cells. There's a hematopoietic, which is for the blood cells, like the platelets, the white cells, the red cells. And then there's the mesenchymal stem cells, which the connective tissues come from. But a small number of cells within the mesenchymal stem cells are called the skeletal stem cells. And they're the ones that are going to become cartilage and bone. And what we found out in this study was that this factor was working on those skeletal stem cells. How did we figure that out? Well, let me just both, a major part of my talk is discussing the skeletal stem cells, so I want to tell you what they do. They differentiate into bone-forming cells, so you grow bone. They also differentiate into cartilage, so at the right time, there's cartilage formation. They also can stimulate the HSCs to make cells, and they also can regulate calcium and phosphate levels in the body, so they're really important. What could they be used for? I'm saying could because we haven't really been real successful with this yet, but theoretically we could treat fractures with them, arthritis, osteoporosis, maybe joint injuries. We could use them to regenerate cartilage. And I won't talk about it tonight, but we have used them to regenerate cartilage. I'll show you how we manipulate them tonight to treat fractures. But the challenges are, and why this is kind of a fun talk because I'm showing you animal work, is that they're hard to, they're heterogeneous. And in different parts of the body, they can do different things. And as you would expect, stressful conditions like inflammation and aging, there's probably a lot of skeletal stem cell dysfunction. In fact, we can talk about it some at the end of my talk. One of the things we find as we get older, as I showed you with the men and the women, that the bone mass slowly goes down, and it's most likely because the number of skeletal stem cells that become osteoblasts that form bone, just they either aren't that many or they dysfunction. In fact, we'll probably get to that in a minute. So I hope I haven't bored you all silly. Okay. So we found that there was something that was coming out of the brain that was going down to the skeleton and making bone. And that started a long journey, which I'm going to show you now in pictures. The one thing we hadn't been able to find in the first study done that was led by Dr. Herbert was actually something, the factor that that was causing what was allowing the bone to form. And Muriel Babby, who came into the lab, was just lucky enough to get the brain tissue from the ARC in the knockout mice. And through some sophisticated molecular biology, she found a molecule which we're going to call CCN3. And CCN3 was in the brain, and it wasn't found in the animals that didn't have the estrogen receptor knocked out, but it was found in the ones that did have the estrogen receptor knocked out. Okay. So then we said, well, we may have found the molecule that's doing all this great stuff. And so this next experiment was also very interesting for me, because I'm a clinician and a rheumatologist, and I, again, never would have thought to have done this. But what they did was they took a regular mouse and they were able to knock down this with a probe, the CCN3 that was made in the brain. And then once they got rid of the CCN3, they saw that the bone mass went down. So that was a very important study, because it showed if you could get rid of the gene that was making the CCN3, which they did, the bone mass went down in the mice. So that was a big, big, that was a very big experiment. And then we did other experiments that showed when we brought the CCN3 that you could see great increases in bone mass. So looked like CCN3 was the ticket. So then we had to see if CCN3, how it was working. And so that's when, with help of our colleagues at the time at Stanford, we were able to find the skeletal stem cells, or isolate the skeletal stem cells in the mice. And when we gave the skeletal stem cells, we had them in culture. And when we gave them CCN3, we had a whole bunch of bone. And then when we actually did a number of studies, but one of them is we created a fracture and we let it heal on its own. And we created a fracture and we gave the around the fracture callus CCN3 and skeletal stem cells, and you can see what a wonderful big healing we had there, and whether it was males or females. So we then started to see that the CCN3 was the molecule, and when skeletal stem cells were exposed to CCN3, they made bone. In this case, they made wonderful. You can see the fracture healed very, very well. Okay, now you think we'd done enough with the CCN3. May I say, you ain't seen nothing yet. Okay, so now I'd like you to think back, and we're now going to a different stage in life. We're going to talk about the skeleton in pregnancy. And this, with pregnancies, it's a very interesting time. The fetus needs calcium for their bones. So in a normal pregnancy, women lose a little bit of bone, not very much, 3 to 5%. That's why the obstetricians say take lots of calcium and vitamin D so that the fetus can have a strong skeleton, because if you don't take calcium and vitamin D when you're pregnant, you lose more. Okay, and actually, then there's if you breastfeed, there's lactation. Women can lose a fair amount of bone, up to 10%. And by the way, a T-score in the spine is usually about 10 to 12%. So you can lose a whole T-score. You can, not women don't necessarily, but they do lose bone mass. when they're lactating, because again, the fetus needs that calcium. But then when they stop, usually there's complete recovery after they stop lactating, as long as they don't have too many children within a short period of time, etc. But what we never really thought about was, okay, this is going to get a little complicated. Okay, I understand how during lactation you need to get calcium out of the bone. So osteoclasts take calcium out of the bone. And we also knew that PTHRP, and I'm going to show you a picture here, which some of you may or may not have seen. This is actually kind of complicated, but let me see if I can kind of make it simple. So here's how the body gets calcium into the milk during lactation, okay? When the infant suckles, there is release of prolactin, and from the breast comes PTHRP. Now, PTHRP is super important because its receptor is on the osteoblast, and when it stimulates not only bone formation, but actually it stimulates osteoclasts to go and resorb the osteoblasts make rank ligand, which makes osteoclasts to resorb bone. At the same time, this is a most interesting molecule because it stimulates bone formation. So you have to have bone formation to make the rank ligand, so the rank ligand can make osteoclasts and then get calcium out of the bone for the infant, okay? Got that? Well, there's one piece of it we never thought very much about, and that is that where do the osteoblasts come from? Where do the osteoblasts come from? And I'm not able to look at the chat right now. So if people have questions, I guess they can go ahead and ask them, but I can't look at the chat right
We'll
now.
do that at the end,
Okay.
Dr. Lane.
Okay. All right. So, and I also want to show you another thing that we knew in, oh, great. The other thing that we knew in, for a number of years, that the osteocytes would sit in the middle of the bone. When you're lactating, they also can resorb the calcium around their lacunae and contribute to this process, okay? But that's only a small part of it. All right, so now, where does my story continue? So what happened is that we said, okay, we know that CCN3 makes skeletal stem cells become osteoblasts. And then if they become osteoblasts, PTHRP can tell them to mature and then make rank ligand to tell the osteoclast to resorb bone for the fetus. So if you don't have CCN3 to activate the skeletal stem cell to become an osteoblast, you're not going to make milk or very much milk, and the offspring might lose bone. And that's exactly what we did. We took the lactating female mice, we got rid of the CCN3, and then look, these were the offspring, and this is about a week later. They lost weight and they lost bone. So, so let me just show you, and this was published in the New England Journal of Medicine in November. Every once in a while, they do little articles about exciting basic science. And this is sort of what I've just been telling you all. And the New England Journal and I are right now having a little discussion about my subscription. So I took a picture on my phone, and this is what you got. But anyway, long story made short, this is how the body has figured this out. In the same time, you build bone while making milk for the infants, because if you don't build the bone, you don't get milk, and also, or very much milk. And secondly, the skeleton collapses, and you can't have the skeleton collapse because then the mother can't feed the offspring, and then the offspring don't live. So this is survival. This is really the basis of, if you think about evolution, how important this is. So anyway, CCN3 coming out of the brain goes to the skeletal stem cells, says make osteoblasts. So the osteoblasts, then the PTHRP activates them. That comes from the breast to make rank ligand that then stimulates osteoclasts to resorb bone and put calcium in the milk. At the same time, you keep making CCN3, so you keep preserving the skeleton. And of course, it's not perfect, but it's enough to get women through lactation. And then weaning, the system turns off. We aren't exactly sure all the triggers of CCN3, but it turns off. And then the skeleton eventually comes back. So that's my first story. Now, I'm just going to say that, it's 2025. So my colleagues that are the major workers in this story have obviously patented CCN3, and hopefully sometime in the next 10 or so years, maybe it'll be a wonderful therapeutic for osteoporosis. But what's kind of interesting from this work, and I'm just going to share this, is that I told you that skeletal stem cells are a small part of the mesenchymal stem cells that are in our bone marrow. But some scientists have been very clever and found that if you give, if you will, you can engineer stem cells and they can actually change a little bit. So the idea is you could actually make these exosomes that circulate around, and then they would get into the mesenchymal stem cell and stimulate it to make skeletal stem cells so that we could make more bone. And I think that that's a high possibility that we'll figure out how to do that in the next few years and have more skeletal stem cells, which would be good. Okay, so that is my first scientific update. And I have another one, but I'm happy to take questions about that one now before we go on to the other one. It's up to you.
Yeah, maybe that would be good, even though.
Yeah, because I'm going to change subjects a little bit. So, I mean, it's still skeletal stem cells, but it's a little different. So I'm really happy if anybody wants to quiz me on all that crazy science.
Let me see. Is anyone, let me look and see if anything, I'm just looking to see if anything. One person asked if this process would actually in any way have any detrimental side effects.
Which process? The idea of the one I just mentioned in
Either-
terms of
Either the CCN3 or the PTHRP. Either one of them.
It's an interesting question. I don't know yet. One of the things that has always limited us in the treatment of osteoporosis, and if some of you have, like with the anabolic agents we have right now, the potent ones, including the PTH compounds and the romosozumab, is they require osteoblasts to be present. And even though they work pretty well, there's a lot of heterogeneity in people's different individuals' responses. And I suspect that a lot of that heterogeneity is related to the number of skeletal stem cells that are actually able to become osteoblasts, because the number of osteoblasts I believe, is more limited in some people than others. But we haven't had anything, and I mean anything, that actually works to make the skeletal stem cells become osteoblasts, besides this CCN3. So do I suspect that there will be side effects? Well, who knows? But at least finding out how to stimulate the skeletal stem cell to make more osteoblasts is really definitely an unmet need. And some of my research colleagues from that group that did most of this work are actually looking at the skeletal stem cell and trying to understand the CCN3 receptor. And once they figure that out, maybe we'll never use CCN3, we'll just use something to activate the receptor. Who knows? But
Right.
it's just, I just wanted to take you back to something that we really haven't really even been able to study, because for a couple of reasons. One is that the markers to actually isolate the skeletal stem cell have just now, over the last 3 or 4 years, maybe 5 years, been available, where people really believe that this is an important stem cell niche. So it's early days, as I say, early days. But will there be side effects? Gosh, who knows? And I don't know. But at least understanding how we could potentially get people to have more osteoblasts so we could make more bone
Very exciting.
is probably the exciting piece of this. And last but not least, as I said, evolutionarily, how nature figured out how, to keep mothers' skeletons intact and make milk at the same time. That, I think, is really cool.
Yeah, that's amazing. Just even the process of how you were able to target that going into the cells themselves. It seems like that's like, I don't know, super science to be
Well,
able
it
to.
was a team effort. If you look at the paper, there's about 20 authors. I'm only one of 20. And it was UCSF and Stanford and UC Davis and lots of people. We all worked on this team science for sure.
Very, very good. Well, I think people are asking more about things that we could talk about after, if you wanted to continue, Dr. Lane. Unless you.
Okay.
Yeah.
Okay. All right. So now I'm going to switch to an area that's been something that I have been very, very interested in for a long period of time, because, as was mentioned, I'm a rheumatologist, and rheumatologists, we take care of patients who have inflammatory diseases. We often use steroids, glucocorticoids, prednisone to reduce the inflammation. Now, over my career, we've developed amazing biologics that really reduce our use of prednisone or glucocorticoids. However, we still use them. And one of the things that glucocorticoids do is they reduce bone mass and bone strength. And but they also do some other things. If any of you have known anyone or been on steroids or prednisone, you know that they can increase your appetite, sometimes people gain weight, blood sugar goes up. Lots of things that actually, you can have cataracts, lots of things that actually we associate with aging or older people. So studying glucocorticoids' effect on bone has been one of my passions, or something I've been very interested in for about 30 years. And one of the reasons that glucocorticoids are so bad for bone is there's just no bone cell that gets away from from glucocorticoids action. So in terms of osteoblasts, they decrease the number of osteoblasts, they decrease their activity, so you have decreased bone formation. Higher doses, glucocorticoids also can cause osteocytes to die or apoptose and increase sclerostin, which inhibits bone formation.
Excuse me 1 second. Could you just define what glucocorticoid?
Oh, steroids, prednisone,
Thank you.
prednisone,
Okay.
prednisone,
Thank you.
steroids. Does that help? I'm sorry.
Yes, thank you.
Cortisone, prednisone, methylprednisolone, the things that we use when people have asthma attacks, for inflammation, for poison ivy. In short term, they're good, but long term, they cause real problems for bone, and the muscles become weak and they whittle away, so people fall. So there's nothing good about glucocorticosteroids. They cause osteoporosis, and we see lots of fractures. Okay. Many, many years ago, in my lab, we became very interested in study how steroids affect bone. And then also we started looking at ways that we could overcome the steroids' bad effect on bone and reverse it with parathyroid hormone, PTH. And then just kind of out of curiosity, we did this study in mice where we treated the mice with steroids and they lost bone. We treated them with steroids and PTH and we were able to preserve and increase the bone. And then we also gave them a bisphosphonate residronate with the glucocorticoids, and we also were able to hang on to the bone, maybe not quite as much as we did with the potent PTH compound, which was teriparatide. And at the time, we were looking a lot at bone mineral, the mineral composition of the bone, and how strong it was. And we did notice that the PTH didn't have as much mineral as the PTH plus the bisphosphonate, but that was okay. We weren't too worried about that. And this is a very scientific slide, but it just shows you that when you give people that are on prednisone take PTH, and that can allow them to form bone in the presence of the steroid. And it just does it through inhibiting some of these inhibitors of bone formation, but the residronate, it also makes bone strong, but because it inhibits the mineralization inhibitors. So they work for completely different ways to make bone strong, and that's okay. So I hadn't thought about how steroids affect bone for a very long time. But when my colleague, who was part of this other project I just showed you, could isolate these skeletal stem cells, I said, you know, I want to know something about these skeletal stem cells that become bone cells. I want to know what steroids do to these skeletal stem cells. And the reason I want to know was not just because the steroids cause bone loss, because the steroids cause something else that some of you may have heard of, and that's, we call it osteonecrosis, where a little bone can die when you're giving steroids, and the bone collapses sometimes. And I was kind of interested in this. So I got my colleague, Tom Ambrosi, who was at the time in the Stanford lab that discovered all these that characterized all these skeletal stem cells. And I said, let's just do a really simple study. We're going to take mice, we're going to give them for about 60 days some steroids. And then we're going to, after say 28 days, we're going to give them PTH, which is how I would treat a patient. I would give them steroids, and then the steroids would cause bone loss, and then I would give the PTH to recover it. And we did that. And as you would not be surprised, you can see that at day 56, the steroid-treated mouse had about no bone, and the PTH and steroid-treated mouse had a little more bone. But that was not at all the interesting part of this. The interesting part was, no surprise now, some of you may have heard of single-cell RNA-seq. And what we can do in the lab now, and I'm not saying it needs to be done all the time, but we're able to isolate from any tissue, this is the bone tissue, the cells that are in the bone tissue. And then we're able to look via their gene expression, well, we can figure out, number one, what cells there are. That's what this picture tells us, the different cell types. But this down here tells us via the colors of these circles if genes are being expressed or genes are not being expressed in these different cells, okay? So if you look at cells that are going to become either bone or cartilage, and you look at the steroid-treated line, there's almost nothing happening there. Steroids definitely are stopping bone formation. But if you give the steroid and the PTH, this is dark means good here, you're getting some bone formation. But then we looked at blood vessels inside the bone, the endothelial cells. And we couldn't figure this out. But all of a sudden, we see that these steroid-treated mice were making blood vessels. And if you gave PTH, they weren't making blood vessels, or they weren't making the genes that make blood vessels. Okay, so this was, we didn't understand. The reason that we were a little confused is because in my mind, steroids cause osteonecrosis. The bone dies because the blood vessels, there aren't blood vessels. So anyway, just to make this a little less complicated, we isolated the skeletal stem cells and we found that you stopped making bone when you had the prednisone by itself or the steroid by itself. You gave PTH, you got it. Same with chondrocytes. But then the next thing we saw was that, to our surprise, you had more endothelial cells, more blood vessels when you gave the steroid alone. But then the weird thing is the blood vessels were irregular. They were abnormal in their size and what we call their phenotype. So that was really unexpected. So then we did something that is kind of a fun little trick in the laboratory that we can't do in people. Is what we do is we take skeletal stem cells and we put them in a graft over the kidney capsule of mice. And the reason we do that is because a kidney capsule gives them all this blood supply, and then we can see what happens to the skeletal stem cells. And then, so we did that for 3 weeks, and then we took out the skeletal stem cells, and we looked at what they'd become. They'd become endothelial cells, stromal cells, etc. And then we looked, and we saw what genes were being expressed. And interestingly, with the presence of the steroid, we saw these senescent cells, and senescent cells are associated with aging. But we also saw these pro-endothelial cells. Again, these are blood vessels that were really high. But then when you gave with PTH, the skeletal stem cells weren't making too many of those endothelial cells anymore. Okay. So what we did by looking at gene expression is we found a molecule called basigin that was being made in the presence of the steroids in these skeletal stem cells. And that was the reason that we were seeing. And then we found that when basigin was around, you didn't make bone, you made less bone, etc. And before I go on, I want to do with all of you the same thing I did when I heard this. What is basigin? Anyway, it's a molecule, and it's I'm not 100% sure what it does. It has a variety of functions, but it regulates a number of things. In fact, interestingly, it's involved in spermatogenesis, so it helps sperm in males to increase in numbers. But it's expressed in many cell types. And what became interesting to us is it's expressed in endothelial cells. So we did a few more studies, as you can well imagine. And really what we basically, all this shows us is that when we took the skeletal stem cells and we gave them basigin, we got a lot of blood vessels, but if we gave the antibody to basigin, it went away. And so then we did a study where we gave glucocorticoids, then we gave the steroid with the PTH, which we know is going to form bone, and then we gave the steroid with an antibody to basigin. And what we found was when you gave, as we would expect in people, when we gave the steroid by itself, the bone mass went down. When you gave the steroid with the PTH, it went up, which is what happens when we treat patients on steroids with PTH. But if you gave the steroid with the anti-basigin, the bone mass went up also. So what we found is that this basigin, in the presence of, when you give the steroids, basigin tells the skeletal stem cell to become a blood vessel cell, an endothelial cell, not an osteoblast. But if you block that, you can make it go to osteoblasts and not to endothelial cells, so you don't have the funny looking blood vessels. So this is just, to me, what wearing those Google goggles is like. Bone biology and modulation of bone mass has changed because we've identified the skeletal stem cell, and that cell appears to be responsive to molecules that drive its maturation to either bone or other cells. I've shown you how the brain, through the production of CCN3, and maybe we'll find other molecules, maintains bone mass in women while we're lactating so that we don't fall apart and we can then get strong again and reproduce again. Definitely survival of the species. And we know from other studies that maturation of these skeletal stem cells is probably altered in aging and other diseases, and that is where there's great research to be done now. Now we'll talk about steroids, which we use as needed in our very ill patients. And we now know that they alter the skeletal stem cells directly, and instead of sending cells to become osteoblasts, they send them to become endothelial cells to transport red blood cells and oxygenate bone. If you block the molecule basigin, you get the normal osteoblasts like PTH. But what's interesting about the basigin, and I really couldn't find a very good picture, so I'll have to just describe this to you, is that the vessels that get made that these endothelial cells produce are very abnormal. They're altered. And we think, although we haven't yet done the studies to prove it, is that these altered blood vessels may end up being why we get osteonecrosis of the bone, which is an unfortunate side effect of glucocorticoids. So we just this week put up our research on a website called BioArchive. It's run by Cold Spring Harbor. And what it does is it allows people to put up a publication before it gets published in peer review. And so we put ours up, and we hope that this work will, within the next few months, hopefully be published in Nature Communications. But I think that we're now seeing, by studying the skeletal stem cell, we are learning so much about the skeleton and aging. And I think by identifying this cell and how it works and how to make it work better, things like osteoarthritis and osteoporosis, maybe we may find even more ways to cure this disease. And I think that's all I got, ladies.
Well, that is plenty. I want to thank you. This is quite interesting to see exactly what you've been doing all this time. And let's see if we can answer a couple of questions. Would that be all right?
Yep.
I want to thank you for everything you've already shared. Let me go ahead. People are concerned about the corticosteroids,
The steroids, sure.
steroids. I've been reassured that that's not a problem. Is that true?
In terms of what in terms of
Inhalers for
oh, okay, yeah, that's a
bone.
great question. Yeah, that's a great question. So we use the steroids in many different ways. You're right. We inhale them. We use them topically for skin problems. We give them systemically. I'd say the challenge, okay, in terms of an inhaler, I could tell you this data pretty well. If you use it as prescribed, no problem, okay? But if you use it more, then yes, it can be a problem. And we have to be careful because more and more of the inhalers are becoming more and more potent. So if you're using it more than prescribed, um, that's where we get into trouble. And another way we get into trouble is generally, like when I treat systemic lupus erythematosus, an autoimmune disease, I start with steroids, but then I usually switch them to a steroid-sparing a steroid-sparing agent that'll control the disease. But people that have lupus, for example, flare, and they take steroids on and off, and steroids are probably the most cost-effective medication we have, and all of you know that the cost of medicines and medical care is going up, so we still have a lot of people using them more than they should. And that's okay. Sometimes that happens, but we have great medications to prevent the bone loss. But what we don't have medications for is for that osteonecrosis, and that, just understanding that a little bit. And I didn't show you because I didn't want to give you yet another basic scientific topic, but I'll speak to it. We've also, one of the things that happens with aging, most of us know, is, our skin changes and our blood vessels become a little more fragile. Like you punch somebody, you get a punch and you get a big bruise, right?
Yeah.
Well, we looked, and also steroids in my laboratory are a way I study accelerated tissue aging. And what we found in old mice is pretty much what we found when we gave steroids to young mice. Instead of osteogenesis, we saw more endothelial cells. And when we looked at the skin, under the skin of old mice, we saw these funny blood vessels that we could switch to more normal morphology by giving them anti-basigin. So I think basigin is going to be involved in aging and all of the tissues that are generated from the mesenchymal stem cell. But I didn't want to get into that too deeply. But I think we will see, we're understanding some of the switches, and, it's early days. Okay.
And it also seemed like from that last slide that the SIGIN seemed to give you a larger amount of bone growth than just the PTH.
Well, it's,
Yeah.
these are mice.
Okay.
And these are mice, and, I'm not quite sure, what the equivalent dose would be in us, but at least and these are a small number of mice, okay? Because I don't have an NIH grant for this work, so we do it on the, we kind of do it with extra funds that we can garner from other things. And so I would say I wouldn't, yes, I saw that and I go, oh my goodness, but I didn't necessarily take that. I would take it as the same direction. At this point, the numbers are too small to make a big difference, but it was encouraging. And I've had a number of patients that I've treated with PTH for many years. I did a number of seminal studies with it in older people that had osteoporosis, because when I was first doing my studies, you had to be postmenopausal woman with osteoporosis on steroids, couldn't give to anybody else. And a lot of my patients would come in and say, Dr. Lane, and I was blinded, but they would say they felt better, their muscles felt better, and they just felt like a lot of their musculoskeletal system was working better. And I just said, okay, I'm all right. But there may be some biology to that. Anyway, so all good.
I know that one of our members, several of them actually have had PTH issues because it was overactive.
Yeah, you have the medical disease of hyperparathyroidism, where you get, little hyperplasia or little tumors in the thyroid. And that requires, sometimes surgery, medications, and with that can come bone loss. And so there's protocols now. If you have hyperparathyroidism, and obviously that's diagnosed by hypercalcemia quite often, or kidney stones. And that requires, medication, surgery, and sometimes bone loss. So that's something that requires careful monitoring of the skeleton. Yeah.
One thing I wanted to ask you is, how do you think, I mean, just in your humble opinion, what are you talked a lot about inflammation, and I just wonder, is that an issue you could speak to at all, or address that, like, especially in terms of our diets today?
Okay, well, let's first talk about inflammation. There's one thing
Okay.
that occurs as we age, and that there we tend to have, it's part of aging, chronic low-grade inflammation. And it's subtle, it's not overwhelming, but it is there. And that's one of the reasons that, like, we have these chronic inflammatory diseases of aging, of which osteoporosis and atherosclerosis are two of them. So we can predict heart disease by people who have osteoporosis. We can predict osteoporosis by people who have heart disease. So now the question you ask is, can diet affect this? And the answer is a little bit. The answer is a little bit. And it's been shown that the Mediterranean diet is a little bit anti-inflammatory. So one of the things that the elders are doing now is, two things: cutting out all the synthetic sugars and processed foods like, sausage and salami and additives, a lot of additives. We know that those individually aren't bad, but together are not good. And then the foods like the Western diet with steak and potatoes and fat, that if you look at that diet versus a Mediterranean diet, which is fish and nuts and vegetables, that those tend to be lower in inflammation, they don't induce inflammation. Whether they reduce it, I can't say, but they don't increase it. So those two things seem to be what is coming out of the studies that are being done looking at the effects of aging. Now, that's important for the skeleton, I think. I mean, I'm just getting to know the skeletal stem cell, but it's no mystery that one of the things that happens as we age, and if I went back to that first slide I showed you about men and women, one thing that happens about age 70, 75 is we just slowly lose bone. Now, we've always kind of said that's because we think osteoblasts get tired, but I now believe it's most likely that the skeletal stem cells aren't dividing as much. They're either more inhibited in their dividing, or less of them become osteoblasts. And so that's really where our research needs to go now. We need to understand the microenvironment of the skeletal stem cell. I now have a molecule that can make osteoblasts for you, but you can also ask the question is, what's inhibiting it from happening in general? So those are some of the things that we need to focus on.
Yeah, that's really good. That is so helpful. Someone in the group asked this question, and I don't want to keep you forever, but if you don't mind answering this.
No, it's only 5:09 for me.
Um, how someone with high levels of PTH, hyperparathyroidism, which pulls the calcium from the bone, is being used to build osteoblasts and build bone. Could you explain
Well,
that?
yeah, okay. That's actually a really great question. And I used to actually have a slide about that because it's a really good question. Okay. So, hyperparathyroidism. In hyperparathyroidism, the thyroid level, the PTH level is high all the time, okay? And that creates a lot of osteoblasts, but also creates a lot of osteoclasts. And unfortunately, osteoclasts are so much more efficient than resorbing the bone than osteoblasts are at making it, you lose bone, okay? So osteoclast chews up the bone, but it takes, a full remodeling cycle to fill up a hole in the bone takes 4 to 6 months. So you're never going to win. So hyperparathyroidism, you make bone, but you lose it faster, okay? And that's kind of, some people can have hyperparathyroidism. We don't do anything because their bone is fine. They don't lose bone. But if you lose bone, develop kidney stones, that's when you go in. Now, why can you use then PTH to treat osteoporosis? That's a great question. Because when you give the PTH injection, the level of PTH goes up and down. And it goes up and down over 20 minutes. The level of calcium goes up and down over another 20 minutes. But then that sends the osteoblast into making bone. And even though you do make some osteoclasts, it's not, it's more positive than negative because the PTH isn't there for very long. But when it's there all the time at a high level, that's the trouble. But you give a shot once a day, you get bone formation, you get a little resorption, but by far and away, you get more bone formation. Does that make sense? So it's
Yes,
quotidian versus constant, as we say.
yeah, I like that. That's great.
But that was a hard concept to get across. And actually, let me just mention to you that over the years, nobody likes to give themselves a little shot every day, although it's not a big deal. So people have tried to put PTH in a patch or PTH-like compounds in a patch, a transdermal patch. And there's a company in Israel now that actually has figured out how to give PTH orally. And the reason that PTH has been tried orally, but the problem is it gets absorbed and it stays there too long. The serum level stays there too long and the calcium goes up. Okay, so we haven't been able to get an oral PTH that can go up and down and the calcium goes up. Now, but theoretically, this company in Israel, InterBio, is able to do it. And I think if they're not already, they should be entering maybe a phase 3 study. And then we also tried the patch. And the patch seemed to work pretty well, but it didn't gain as much bone mass as the injection. So nobody's taking the patch. So, but that's what's happening. There's some interesting stuff happening, but it's all about the kinetics of the serum level that is what's critical.
Very interesting. Okay.
Oh, and if you know anybody that takes PTH, because I've been studying PTH forever, it's really important where you actually inject the PTH. And by far and away, the best place is in the abdomen. So if you know anybody on PTH, you can take it for a couple of years, just like draw a big circle in the abdomen and every day you go right around. So it takes 100 days to go all the way around. So, but if you do it in the arm and the leg, it gets absorbed, but not as well.
I don't hear of anybody on that type of treatment here. Is this something that's being done in California, but not?
No, Forteo, teriparatide,
Oh,
abaloparatide,
oh.
Timlos, that's what I'm talking about.
Okay.
They don't call it PTH, but it's teriparatide, abaloparatide, etc.
Yeah, and the anabolic drugs. In other words, okay.
I just got my prescription for that today.
There you go.
And I'll be talking to my endocrinologist tomorrow because I have a steroid type treatment for alopecia. And I'm also seeing somebody for interstitial lung disease. And so I'm not fussing at my endocrinologist. I know everybody's real busy, but I'm thinking, hey, before we start this new regime, let's make sure we're doing more harm, more good than
More
harm.
good than harm. Oh, yes. You'll be fine. You'll be fine.
Well, it's good to hear. Lori, did you have a question that you'd like to talk?
Yeah, it's kind of So how does it work on the ground regarding steroid-induced osteoporosis? The issue was my mom. She was on prednisone for a good 4 to 5 years for rheumatoid arthritis, and she ended up having to have a hip replacement because the bone just degraded. I'm not sure if it was because it was
That was osteonecrosis.
that's what I'm
Probably.
suspecting.
That's exactly what I was referring to about the blood vessels. Yep.
It was just the other hip is not so good, but she's got a ways to go. But it was the one hip that got really bad very quickly. So a year ago in September, after a very high dose and then titrating back down before starting on a biologic, after 4 to 5 years, she should have been on a biologic much sooner than that. But
It's okay.
so if she were to start on the PTH like for Teo, would there be any need, like you said, that the funky, strange blood
Blood
vessels,
vessels. Well, I think that
is that a concern still after being on the prednisone, or was it only when the prednisone was done at the same time as the PTH?
no, I think, first of all, these are just mice, but I think the good news is PTH, I don't know if it works to prevent osteonecrosis, but it definitely sends the skeletal stem cells. Yeah, I think PTH probably works just as well as the anti-basigin. Yeah, I think that PTH keeps the cells going to the osteoblasts and less going to the abnormal endothelial cells.
So
But
now
we'll have to, I mean, but we haven't, I haven't tested that clinically, but it is my impression. Now, the challenge with that osteonecrosis of the hip is where it is. And so probably that one patch of bone that your mom had was probably near the cartilage, which causes the joint to collapse. So it does depend where the dead bone occurs. But at any rate, I just think Forteo would not hurt at all.
yeah, it's just a matter of trying to get it approved and stuff.
Oh, I think if she's on steroids, it's pretty easy.
Yeah, she's off the steroids now, but it's just a
But
matter
if she has osteoporosis, well, anyway,
she did have fractures and mild compression fractures in her back.
then she's good. She can get it. Right.
Yeah.
But I know the medical system is very tough that way. Boy, do I know. I know.
So which of your studies then would be best to print off and provide? I'm in Ontario, our healthcare system and trying to get drugs is a little bit trickier, different.
Oh, trust me, it's no different than, I think it's easier in Canada, trust me.
Okay. Which of your studies would be good then to print off and provide to help encourage her approval of getting an exceptional access to get?
Oh, I just think that you should just grab the studies that you just need the studies that have like been in the New England Journal of Medicine. The first authors, Ken Sag, SAAG, alendronate versus parathyroid hormone for the treatment of steroid-induced osteoporosis. There's a good number of them.
Okay, I'll do that. Thank you.
Yeah, those are excellent questions. We have one more question from,
Right, Karen has been patient.
yes,
Hi, thank you.
Patient.
Are you able to hear me okay?
Very well, yeah.
Okay, good. Thank you. I stepped out of a conference here to talk, so I'm glad it's working. I had a quick question with your background with Forteo, with the parateritide. Uh-oh, it just went blank. Am I still?
You're still with us.
Okay,
yeah.
good. I was very briefly on it and experienced an increase in my glucose level. I'm not diabetic, but I had a very large increase on multiple days in my glucose levels about the time that I would take the shot. And I did go find a study. It was a small study that showed that could have a negative impact on that, associating it with perhaps insulin resistance. And I was just wondering your thoughts on that. they did think that it was transitory, but
Well, I haven't, I think it has been reported, but it's not very common. And I haven't seen it sustained. But, you know, there's another very good anabolic agent out now, Evenity or romosozumab.
yeah,
You know, that's plenty potent. So if
those
you,
are my choices. Yeah.
I
So I
would
was,
probably, as long as you haven't had any heart problems in the past year, I'd probably go to the romosozumab. Now, romosozumab is very good, and I recommend it a lot.
okay.
But I want you to all remember something about osteoporosis, and that is that it's a diagnosis, you know, in the sense that it's just because you're treated, it's not going away. And so, like it's high blood pressure. If you have treated osteoporosis, you have treated high blood pressure. So when I meet patients and I say, okay, your bone mass, you have a high risk of fracture, and I want to treat you, I'm going to be following you if you're 60 years old for the next 25, 30 years, and your bone mass is going to go up and down. And so the reason I say that is because I think romosozumab is great, but at some point you may need to revisit. And so it's worth, you know, remembering that,
Right.
you know, to look into this, why your blood sugar went up. I'm sure it's possible and all that, but just remember that
Right.
1 year of romosozumab is not going to cure osteoporosis. It's, you know, usually a
Right.
journey.
And I'm 56, so I'm trying, and it's, you know, I have very low density, so I'm trying to figure out what I'm going to do. My system just seems very
Well,
sensitive to everything.
I think that's actually without, I think the issue of how aggressively to treat when you're in your 6th decade of life versus your 8th or 9th. And it's important to remember this. Good news, unless you've, fallen and broken a few bones, even though your bone mass may be low, when you're young, your bones are still pretty strong. And 56 is pretty strong, pretty young. But if you take the bone mass with age, the bones just change a bit. So, Karen, you've got some time.
Okay.
I would maybe not use the potent ones right away. I might go with denosumab. You can be on denosumab as a slow anabolic over 10 years. It goes from osteoporosis to normal bone mass. So, but age really is important because as we get older in our 8th and 9th decade, you can have relatively normal bone mass, but your bones break because like age, they just get old. And so, but you're young, Karen, so you don't have to use the big guns yet unless you're seriously fracturing.
Hey, this is Robert. Can I have one quick question, please?
Yes, you can.
Oh, thank you.
Wherever you are.
Thank you. I'm not sure this format. I've never been on it before. There's so many big words. I'm not sure if I'm asking the right question. If you don't want to answer it, just tell me, of course. I'm 76. I have a score of my DEX score of minus 2.6. And the endocrinologist gave me a shot of Prolia November 14th, so about over 2 months ago. And I've been in hell ever since with muscle and bone pain. And I'm taking Tramadol and 6 Advil a day. And I got a cortisone shot in my hips last week. Can you respond to any of that? And they told me it was really rare to have all these terrible, terrible effects from Prolia.
I agree. I actually haven't ever seen that. Because the thing that's odd about it, is that it's not around all that long. So if you reacted to it like that, it's a monoclonal antibody, and you must have reacted to, it may not be, it may be the molecule, not the whole molecule, but some piece of the molecule. Now, how many months ago did you get this injection?
2.5 months ago.
Well, I wouldn't get another one.
Oh, that's what I was just going to ask you. Should I just switch to Fosamax?
I think that would be just fine at minus 2.6. And first of all, I'm glad that you went and got your bone mass checked. You're a rare commodity. Men over 70, 75 should, and you did. Fosamax is fine.
Or Boniva?
And yeah, no, Fosamax is fine. It's of the oral medications, it's the most potent. You know, you could go get a shot of zoledronic acid, but I would just give you Fosamax for a while, see how you do. Check your bone mass in a couple years.
Yeah. If I get another injection, I'll need a psychiatrist.
Yeah, but you know, what I would say is be sure that that's in your medical record, okay? Because it's unusual, so people would not expect it.
Okay.
That's okay. None of us are truly normal. It's okay. We're all unique.
Thank you so much, and thank you for your work.
Oh, you're welcome.
Yeah, I think we probably need to close tonight, and I appreciate it, but I want to ask you one more question that someone asked, if I could, please.
Yeah, go ahead. Go ahead.
We a member of our group has asked if someone had a parathyroidectomy. Would you still recommend being on a any PTH drug for their osteoporosis?
Well, if I think the most important thing, if it's a total there are 4 parathyroid glands. Sometimes people have even a few more. And yet she had 2 taken out. Well, you know, I think the endocrinologist or the physician will follow the calcium levels and find out if they're being maintained. If they're not, you need calcium, and the physician will follow the bone density and go from there. Those are 2 things to just keep being monitored.
Okay, well, thank you. And also, everyone will ask me this afterwards. So, do you still take patients if you live in California?
Oh, yes, I do. I do mostly telehealth, but I do take patients. Yeah. 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 So I'm happy to see anybody who wants to.
That's great.
Yeah. It's yeah, it's something that I enjoy doing, and I think that, as you all know, that COVID really isolated us and really got a lot of us behind. I'm saying this generically. And now we're all sort of out again and thinking about our health. So that's a good thing.
It's true. Wow. This has been so informative. And, you know, I read I tried to read a lot of the things online about you. And, you know, there's so many things that you've done that we haven't even touched on.
Yeah, but, you know, I've been at this a very long time.
Well, thank you for all.
All right. Lots of pleasure. Everyone have a nice
Been
evening now.
wonderful.
Okay. Take care.
We appreciate it
All right. Bye-bye.
very, very much.
Bye-bye.
Thank you.